Great. Well, welcome everyone. Thank you for joining us this lunchtime to hear about the findings of our deliberation on the public acceptability of linking reproductive health data. I'm Professor Jennifer Hall. I co-direct the Policy Research Unit in Reproductive Health, and I'm going to give you an overview of the Policy Research Unit and what it is that we do, and then some background on the data project and the first year findings, which will lead into Dr. Rose Stevens, who will tell us about the findings of the deliberation, and then back to me for some policy implications and our next steps. And then hopefully we will have about 20-25 minutes for questions and discussions at the end. So we are recording this webinar and that will be available afterwards. We won't record the Q&A session. If you do have any questions or any issues, please pop them into the Q&A box that is being monitored. So to start by introducing you to the Policy Research Unit in Reproductive Health, we were established in January last year and we run for 3 years in the first instance. It's co-directed by myself and Professor Judith Stevenson at the UCL Institute for Women's Health. But we're a collaboration of the universities and organisations you see on the screen here. So that's Oxford, Birmingham, Warwick universities, London School of Hygiene and Tropical Medicine, HALDAR and the Co-Production Collective. So we are a collaboration and we are also multidisciplinary. So we have clinicians from different specialties. We have primary care, sexual and reproductive health, gynecology, public health, and then we have researchers from different disciplines. So sociology, psychology, human rights law, health economics, epidemiology, and we try and bring all those different disciplines and perspectives to the work that we do. We cover the whole of the reproductive health life course for everyone, and we also work in partnership with lived experience experts at multiple levels, so in each of our projects, in our executive and in our independent advisory group. The policy research units, of which there are 19, are set up to support policymakers with their evidence needs, to help them be able to develop evidence-informed policy. So we have a portfolio of 4 core projects at the moment, and those were developed in collaboration with policymakers in recognition of what their priorities and needs were. We have a project on commissioning for women's reproductive health across the life course that's being led by University of Warwick. We have the data project, which will be the focus of today's discussions, which we are leading from UCL. We have a project on delivering quality abortion care for patients with complex medical or social needs, and that's led by London School of Hygiene and Tropical Medicine. And then we have another project led by us at UCL looking at how attitudes to hormonal contraceptions are changing and what's influencing decision-making in that area. So I'm going to focus on the reproductive health data project and the background for that. So for anyone who is not familiar with reproductive health, just a little introduction to what reproductive health data is. So for the data project, we took a very broad perspective of reproductive health. The Policy Research Unit itself is more focused on reproductive health and doesn't include sexual health or maternity. But for this particular project, where we were thinking about the relevant data across the reproductive life course and what would be beneficial to link, we wanted to have a very inclusive definition. So we basically conceptualized it as anything, any conditions, illnesses, or events related to the reproductive system throughout life. So things like infertility, pregnancy, abortion, contraception, vasectomy, and menopause. Now you can imagine thinking about those different topics, that when people experience those symptoms or conditions or events, they might seek care in one of many different places, or they might come into contact with different bits of the health system. So they might see a GP or a nurse in primary care and they might get prescriptions through that. They might attend screening programs for cervical smear or sexually transmitted infections. They might also attend hospitals or treatment in the independent sector for fertility or abortion. They may experience maternity services, and they might attend community sexual and reproductive health services for contraception, HIV testing and treatment. Because people access care in all those different places, the data related to their reproductive health and their care uptake is held in many different systems owned by different people, and it isn't connected. And this makes it really, really hard to do research and policy and service planning because we can only see part of the picture. So we don't have an idea of a national picture of reproductive health. We don't know, for example, the prevalence of different contraception use nationally and how that's changing over time. Because we don't have the linked data or the ability to follow people across their life course, we can't see trends, we can't see patterns across those different experiences. And not only can we not see people's reproductive health across time, we can't follow it across different bits of their health service. So we can't see the journey from first experiencing the symptoms, presenting in primary care, and maybe progressing through secondary care, and how long those treatments and diagnoses take. So we're really limited in the ability to properly plan our services or our policies or evaluate them, and to be able to give people the best possible care. So that is the background for why the data project was felt to be important, both to Department of Health and Social Care and to us from a researcher perspective. And so the data project is a 3-year project. The first year last year in 2024 was all about understanding what's already been happening and what's out there. So we did a review, we spoke to experts in the area about what their problems were and what gaps they faced, and we looked at what different data sets are around. The second year, which is the focus of what we're going to talk about today, was looking at the public opinion on linking reproductive health data. And as we move forward into year 3, which is next year, we're thinking about the practicalities and the processes of actually creating a linked reproductive health data resource. So the scoping review that we've done and that is published, and I think a link will be appearing in the Q&A for you in a moment, we identified 272 studies linking 155 different data sets, which I have to say was a lot more than we were expecting when we were planning the search. But it's good in the sense that it shows that some linkage is possible and is being done. And what was most commonly linked were routine health data sources, so often hospital episode statistics and primary care data, or hospital data with cancer registries. But there were also linkages to census data, to police data, education data, and even the Met Office for weather data. When we looked at what topics were being studied with these links, the majority focused on reproductive cancers, so things like breast cancer, prostate cancer, ovarian cancer, and so on, or on maternal and child health. There was much fewer research studies being published on things like contraception, intimate partner violence, preconception health, menopause, and that is probably in part a reflection of the lack of data in these areas and the challenges of linking the data that does exist in those areas. Very few studies included detailed information on the sociodemographics of the populations in the data that were linked, and so that really prevented analysis of inequalities, really hard to identify either differences in reproductive health across groups and which groups have worse experiences or outcomes. Almost half the studies didn't tell us how they'd link to the data, and so we couldn't then really tell how complete the data linkage was, and therefore how representative the linked data are of the wider population. Only one study actually explicitly set out to look at public acceptability of linking data sets in this area, and fewer than 10% reported any patient or public involvement in them. So we then spoke to a number of experts in the area that included policymakers, clinicians, researchers, service planners, and very much heard from them that there was a real desire to understand reproductive health across the life course and across the health service. There were many questions that they struggled to answer because of the way that the data currently are. And those included things like how common is early pregnancy loss, what are the combinations of contraception, who's using what, how's that changing over time, questions about menstrual health and menopause as well. They also wanted to better be able to identify marginalized populations in the data, so whether that was by ethnicity or migration status, different ways of identifying vulnerable groups and being able to better see what their needs are and how we might be able to meet those. So there was a strong support for linked reproductive health data set that would bring together data to be able to answer those currently unanswerable questions to help improve policy and services. So there are a lot of benefits, as I've just outlined, for potentially linking data, but reproductive health data is also potentially more sensitive than other data, or could be considered that way by different groups of the population. So it's important to think, although there has been quite a lot of work done on acceptability of data linkage in health generally, nothing had really been done around these reproductive health topics, and things around sexually transmitted infections or abortions might be things that people feel differently about. And it's also really important that when we are using and linking people's data, that we bring them along with us on that journey, and we do what the linkage in a transparent way, in a way that the patients and the public are trusting of. There are also within reproductive health some particular practicalities that are challenges for linking data, and that includes the fact that some data in this area is reported anonymously and therefore cannot currently be linked to other data. So in order for us to be able to do that, there will have to be changes in how data is reported, not necessarily in what's collected, but just how that data is reported in centrally. And because, as I showed you before, so many different bits of the health service and the local authority and the independent sector are involved in providing reproductive health care, there are multiple data owners, which makes it more complicated in terms of the data sharing and agreements to bring those data sets together. So the conclusion from year one, that there was actually a substantial body of research linking reproductive health data, but all those studies had brought it together to answer a particular question. There was no legacy data. There was no way that other researchers could access that linked data or go back and use it. And there are particular gaps in domains across reproductive health and populations, which mean there are ongoing unanswerable questions, which meant that coming out of year one, we did feel that there was a need for a secure national linked data resource to support reproductive health research, policy and planning in the public interest. So moving into year two, what we also really recognised was that there was very little previous research on the public acceptability of linking reproductive health data. And that's why we wanted to spend the second year exploring that, and we did that through a deliberative engagement. So I'm going to hand over now to Dr. Rose Stevens, who will explain to you what that is and what we found.
Great, thank you so much, Jenny. I'm Dr. Rose Stevens, and I'm a research fellow also at the Policy Research Unit in Reproductive Health. And I'm going to start with telling you why we chose to run a deliberative engagement. So as Jenny said, reproductive health data can be sensitive, and so it requires public trust and confidence to bring it together in a linked resource. Support for that data linkage and use is likely to come with conditions for how it should be accessed and who should access it, and what are the public's red lines for what should be linked or perhaps what should not be linked. So we wanted to understand how members of the public feel about linking different types of reproductive health data. So we felt that deliberation is best as a method because it's good for complex issues with no right or wrong answers. Deliberations seem to seek to convene mini publics over time. That group is then informed by specialists and case studies and encouraged to share opinions in discussions. These groups are then supported to form expectations and make choices while accounting for the different trade-offs in an issue. So as such, we held the Exploring the Future of Reproductive Health Data deliberation workshops in June and July this year. In these workshops, we set out to answer the question, how can we create and manage a linked reproductive health data resource that helps to drive improved services and reduce health inequalities while protecting personal privacy, fairness and trust? We sought to look at two different parts of this. So firstly, what should the scope of that data resource be? How comprehensive should it be versus thinking about some potentially sensitive topics? And how should it be accessed and protected? So how can privacy be protected whilst also maximising its usefulness? These topics were discussed across one evening and two full-day workshops in June and July. And we were discussing linkage not for direct care purposes, but for this research, policy and service planning purposes. All the materials for the workshops were co-produced with our 5 lived experience team members who were also present at the workshops on the day. And across the 3 days, we discussed many different case studies. And I just want to give you an example of 3 to think about the types of things that were discussed. So we talked about the possibility of linking abortion data from independent sector providers to post-abortion contraceptive access data, maybe in prescription data or community sexual health data. We talked about linking fertility treatment data from HFEA data to hospital episode statistics to look at further complications after this treatment potentially. And we talked about linking endometriosis symptom data, so perhaps painful or heavy bleeding from primary care data to, again, hospital episode statistics data on treatments and waiting time to treatments. So who was in the room for these discussions? We initially recruited 40 individuals, of whom 37 attended the first 2 workshops and 29 were present on the final workshop to vote on the final set of expectations. We had a spread across all the different age groups from 18 to over 60s. We had a representative sample in terms of education and employment as to the UK population. We oversampled for minoritized ethnicities, as well as cis women and trans or non-binary individuals. We had a split of attitudes towards data in the room. So about half of the room were pragmatists towards data. So they had a medium ambiguous attitude towards it. About a quarter were unconcerned, so more positive, more relaxed about their data being used. And then a quarter were absolutists, so negative towards data use. We also had a range of reproductive health experiences in the room. So some participants had experienced miscarriage and pregnancy loss, gynecological issues, sexually transmitted infections, infertility and fertility treatments, hormonal treatments such as HRT or hormonal contraception, and abortions. So now I'm going to take you through the key themes that came up in some of the discussions on the day, and then the final expectations that were settled on by the participants. So overall, there was strong support for using reproductive health data to improve care, prevention, and quality of life. Linking reproductive health data together was seen as key to better outcomes, inclusive research, and service improvements, and it was seen as a need to link pieces of the puzzle together. Linking across topics was perceived to be able to help us better identify unmet needs and reduce inequalities, especially for marginalised or underserved groups. Longitudinal data in particular was seen as valuable for tracking changes over the life course and being able to understand people's health journeys across different service types. On the flip side, participants stressed the need for transparency, trust, and strong safeguards. They were also concerned about whether data would be accurate, up to date, and representative of the groups we were drawing conclusions about. There was mixed views on the sensitivity of reproductive health data in general. Some people felt that it required stronger protections than general health data, but overall there was support for linking even potentially sensitive data, so long as the public benefit outweighed the risks of potential misuse. So coming first to the scope, what data should be included? Participants discussed that no reproductive health data types should be considered off limits, even currently unlinkable data types, if they are de-identified, held securely, and used only for public benefit. Participants felt that all topics were important, yet had the potential to be sensitive depending on personal and cultural context. So they felt that all data should be strongly protected and access should be decided on a case-by-case basis. In terms of the different topics we discussed across the days, here's a few of the ones. Jenny's mentioned a lot of them already, but we discussed abortion and pregnancy history, contraception, different types, menopause, fertility treatments, gynecological symptoms, gender-affirming care, reproductive cancers, and sexually transmitted infections. And all of these data types were seen as important and potentially valuable for including in research and service planning in this data set, but all were considered to have the potential to be sensitive. So for instance, contraceptive data was generally viewed as it was a commonplace practice and therefore low sensitivity, but for some the context really mattered. So one participant said some cultures don't believe in contraceptives, so if this was identifiable data, this would be a problem. For abortion, again, this was recognised as highly important as having included for being able to improve services, but was often described as highly sensitive. And this sensitivity was shaped by culture, religion, stigma, and context, with some communities finding it a very sensitive issue and others not. And then fertility treatments, again, this was widely supported for inclusion as a data type, particularly as it's seen as quite a new technology, so more research being needed, but there were mixed views on sensitivity. So for many, cultural stigma and desire for privacy was noted, but others, they saw attitudes were changing and felt that nowadays things were more out there. The key factors that were driving whether someone thought a topic should be considered sensitive was typically cultural or community norms, whether this topic was subject to stigma, discrimination, or moral judgment, age and life stage. So some of our older participants felt that if there was a reproductive health experience that had happened to them earlier in life and now they were later in life, this was less sensitive than if it was something current for them. And if there was any concerns over consent, re-identification, or automatic inclusion. Off the back of these discussions, a final expectation was drawn up by participants that read, no specific data type is always more sensitive. However, when approving a project, the sensitivity of the project, such as due to the number of participants or cultural sensitivities, needs to be taken into account and stipulations made accordingly. So rather than ruling out some topics fully, transparency and accountability were high priorities. Support for including these topics and using them for research or service planning was conditional on transparency, strong protections, and ethical use by trusted actors. On the transparency point, participants thought that the national data opt-out needed improved public awareness. Some were surprised there was an option to opt out and felt it hadn't been shared publicly very well and felt that it was important people should be informed that their private data was being used. However, in general, participants did see the value in an opt-out system rather than opt-in system to maximise dataset value, with fear that it's going to skew the results if you have a group that doesn't want to share their results and you end up with a very biased population. So moving on now to access and governance discussions. Participants placed high importance on strong safeguards for data access. They expected strict security processes, data minimization, so only providing the data required for a particular project and no more, clear accountability, and meaningful penalties for misuse to prevent repeated misuse. In general, most participants were reassured by de-identified data and saw the benefits as outweighing the risks, but there were some concerns about re-identification, especially in rare or malicious cases. Overall, participants felt that protections should not be so restrictive that they hinder valuable research. So in terms of who they felt should be able to access this resource, the most trusted actors were seen as the NHS, so service planners and commissioners, Department for Health and Social Care for making policy, and UK academic institutions. All of these were seen as expert and accountable. Charities were cautiously trusted as long as their agendas aligned with public interest. And profit-driven commercial or political organisations, non-health government departments or non-UK organisations were the least trusted, particularly where they were perceived to have other agendas other than public benefit. So what counts as public benefit? This would be a project that could improve care, one that served the largest number of people, one that addressed rare or underserved conditions, one that supported implementable policy changes, and ones that reduced inequalities for vulnerable groups. Economic benefit and cost savings were seen as less important, and this purpose of the research was often seen as more important than the user itself for deciding upon access to the data. There was support for an independent approval process led by a diverse panel of experts and public representatives with lived and learned experience. And again, this primary criterion for what they should use to determine access was public benefit. It was felt that heightened scrutiny should be applied where data could be deemed sensitive or if risk of re-identification was greater. And organisations and researchers must demonstrate integrity and commitment to public benefit before access was granted. So moving on to the final expectations, you can see the expectations in full on our full report via our publications page on the website. But during the third workshop, expectations were drafted by two separate groups of participants. They then discussed them together, got feedback on them, went away, amended them, discussed again, and in this iterative process of amendments, settled upon a final set of expectations. And at the end of the day, these were voted upon. The expectations were split into scope expectations and access expectations. So you can see for scope, 17 of the final 29 participants said that they fully supported all of the expectations, and 9 said they supported most of them. This split was broadly represented by those that were in favour of saying all topics could potentially be sensitive and should be treated with strong safeguards, versus those that felt that some topics were always more sensitive than others and should be treated with heightened security. For access, 24 of the 29 fully supported all of the recommendations, and there was really broad consensus and support for the access expectations. So finally, to end with some reflections from participants. In general, participants enjoyed the session. They found it insightful and entertaining. They felt it was facilitated in a way that allowed space for everyone to speak. They thought the topic itself was interesting and thought-provoking, and they generally enjoyed listening to others' views, working in a group to understand how data is collected and how other people feel about its use. Some participants did feel that others were talking too much, perhaps sharing irrelevant information or dominating the conversation, and others felt that they would have liked everyone to sort of participate a bit more or speak up a bit more. But overall, really, I think everyone's feedback was that the conversations were positive and they enjoyed the day. In terms of reflections on the topic, participants said they felt like they were contributing to the future, and even if their views didn't substantially change, they felt that they better understood the context, challenges and processes needed to have a positive outcome and a consensual data resource. There were some final reflections that this really is a difficult and nuanced subject. It's impossible to remove all risk with regard to data breaches, and they were interested to see how this will be communicated to the public in light of what they perceived as increasing mistrust and really centrally focused on transparency. They also felt that the recommendations were well thought out and considered and took into account a best set of practices, whilst also minimising data misuse and protecting public good. So now I'll hand back over to Jenny to talk to you about some of the implications of this work.
Thanks very much, Rose. So yes, bringing together our work from the first 2 years and thinking about the policy implications. So it's clear from the public deliberation that people are willing for reproductive health data to be linked if there's strong protections in place and always with that public benefit as the end goal. There's a clear need from policymakers for linked data to plan and evaluate policy and services and to answer those currently unanswerable questions. But as Rose highlighted, there are some sort of outstanding questions in terms of the sensitivity of certain topics and how that might be different for different groups. So further work with minoritized groups is needed to understand that better. And that will be taken forward by Dr. Neha Pathak, who has an NIHR Advanced Fellowship to work with us on this. And that will help as we go forward in thinking about how we link the data and how we manage access to it to make sure that those perspectives are respected and considered within that. As I mentioned, there are some practical things that we would need to change in order to be able to bring certain types together. So enabling data to be reported in with identifiers or with linkers such as the NHS number. And changing that practice, ensuring that confidentiality is still safeguarded under modern data protection laws, but enabling us to bring in the data, for example, from the sexual and reproductive health activities dataset that is currently reported in anonymously. But all of this has to be done with transparency and building trust with the public. So better communication about what we're doing, how we're doing it, making sure people are aware of the national opt-out, but as our participants said, in doing so, explaining why they shouldn't opt out and how their data is safe and how it's protected and how it is needed in order to plan services for people like them. So the next steps for the data project as we move into year 3, so the expectations from our deliberation will be guiding this future work and any linkage activity to make sure that whatever we do aligns with these values and expectations. As I mentioned, we're planning further deliberation work with minoritized groups to explore those sensitivities better and how to build that into the access. And we'll be kicking off with today and this awareness raising, thinking about how we work with policymakers and with the data controllers to overcome some of those practical hurdles so that we can work towards the creation of a UK-linked reproductive health data resource that will fill the data gaps, examine inequalities and better understand patient experience across the whole reproductive life course as well as across journeys of care to improve policy and services in reproductive health. But not necessarily, that doesn't necessarily mean creating a data set in isolation. We want this to be embedded within the wider work that's happening with NHS data and data linkage and making sure that reproductive health data is part of that conversation, because from what we can tell so far, it hasn't really been considered. So we want to make sure that that is either integrated into there or we're doing something separate to bring those together. So thank you very much for listening. That's bringing to the end our presentations, and we will have about 20 minutes for questions. All the links to the much more detailed information than we have been able to present in this short webinar today are available on our website. Full report, participant summary, infographics. The scoping review is also published. So just before I wrap up, I would like to thank everyone who has been involved in this work. The participants of the deliberations who gave up 2 of their summer Saturdays to join us for these discussions, our 5 facilitators and the expert speakers who also participated in those workshops, Amy Darlington, who guided us in the development and delivery of the deliberation, our oversight group, which included various different stakeholders involved in different bits of reproductive health data, who also helped us with the design, and last but not least, the whole data project team, particularly Lois Harvey-Pescott, our research assistant, and Neha Pathak, who were also involved in writing that final report, and our co-producers, so members of the public with lived experience who worked with us throughout the whole of this year to design, plan, deliver, and interpret the results of our deliberation. So thank you to the whole team. Just before we turn off the slides and move over to the Q&A, that bottom right QR code takes you to a feedback form with just a few optional questions that will just help us understand who we've reached today and also anything we could have done better. I think there will be also a link posted in the Q&A in a moment. So yeah, we will stop the recording now and shift to the Q&A, so please pop your questions in there.